once again, I want to thank you and welcome you for coming to the webinar series from the Eye and Ear Foundation called Sight and Sound Bites. This bi-weekly webinar series, which started in April of 2020, highlights the research at the University of Pittsburgh School of Medicine. Today's topic is Keratoconus, Greek for cornea and Latin for cone, its current and future advancements in treatment. I'm Lawton Snyder, CEO of the Eye and Ear Foundation. The Eye and Ear Foundation supports research to advance care for vision, also for hearing, balance, voice, and cancers of the head and neck at the two world-renowned departments of ophthalmology and otolaryngology at the University of Pittsburgh. The funds we provide from the Eye and Ear Foundation to support research are only made possible because of philanthropic support. And we want to thank everybody who has supported the Eye and Ear Foundation, and we'll certainly be welcome anybody who would like to know more about how they can support some of the work that you're going to hear about today. But this webinar series is certainly something that we just want you to learn from, and we have experts here to talk to you today about this topic. What you'll see, just some housekeeping rules here, is our chat is disabled. If this is familiar to you as a Zoom product, it looks like Zoom, that you won't be able to chat, but what we'll ask you to do is to use the question and answer function, which is at the bottom of your screen. And when we get to the questions and answers at the end, or even throughout the program, you can type your questions in, and I'll read those questions to our panelists, and they will be asked, or answered, I should say. We will ask you to refrain from personal health questions because I won't be able to read those, but if you do have some questions for us, you can email Mr. Craig Smith, who's in the in your invitation. You'll receive a survey tomorrow, which we will ask that you send to us because we do use that information. You'll also be added to our email list for future webinars. So today's program, I'm happy to introduce Dr. Vishal Janji. Dr. Janji is a professor of ophthalmology at the University of Pittsburgh School of Medicine. He's a cornea specialist and a clinician scientist. He'll be joined by Dr. Scott Drexler, who's an assistant professor of ophthalmology at the University of Pittsburgh School of Medicine. He also serves as the director of optometry services and director of special contact lens services for UPMC Eye Center. Thank you both. Dr. Janji, I turn it over to you.
Thank you so much, Lonnie. Good afternoon, everyone, and welcome to this webinar series. I apologize in advance if you can't hear me properly or if you hear people laughing in the background. I'm in the OR, as you can probably imagine from the scrubs. Hopefully they won't call me in front of the case someone else is operating while I'm here. So this is a very interesting topic that we're going to discuss today. I'll try and keep it as simple as possible. As Lonnie has beautifully described keratoconus, keras means cornea and conus really means a cone. So what happens in keratoconus is the cornea basically thins out progressively right from early childhood to about when we are 40, 45 or so. I'll discuss more about that. All right, let's move on to the next slide. This is one of my favorite slides always in every presentation. If this was a live audience, I would have asked you to guess, but this is my financial disclosures. There are none. So in keratoconus, as I said, look at the cornea. This is the front of the eye. It doesn't look normal, really. I mean, to anyone who looks at this patient, and you don't have to be a physician to say that there's something abnormal going on. There's an axial, that is central or paracentral stromal thinning. So cornea thins out. There's progressive irregular astigmatism. For those of you who don't know what astigmatism is, when we use glasses, there's a spherical correction and there's a cylindrical correction. So when things don't seem straight, but they're kind of distorted without glasses, that's astigmatism. Now, interestingly, the estimated prevalence of keratoconus is variable. It's 0.05 to 5%. But these numbers are wrong. I put them on because, since I was a fellow back in Melbourne, which is more than 10 years ago, we used to use these numbers. based on a single study that was published by Bill Bourne, who was a cornea giant at Mayo Clinic in Rochester. The prevalence was about 5%. The study was published in 1986. And after that, there have been so many studies that have shown that the prevalence of keratoconus might actually be 50 to 100 times of what was reported in that 1986 study. It usually presents in the second decade of life, but I have to tell you, with improvement in diagnostic abilities and capabilities in the clinic, we are unfortunately or fortunately, because we can pick them early, seeing more kids now who are not even 10. The pathophysiology, poorly understood. Genetic factors, we know now that about 6 to 8% of these patients, they have relatives who are affected. Usually, within the family, it can be your parents, your uncles, or your aunties. Environmental factors, again, very important. Over the past 10 years, people in Sydney and in the UK, they have worked a lot on sort of figuring out if eye rubbing is associated with progression of keratoconus, and it's really an interesting concept. I'll touch upon that quickly a little later. Biomechanical factors, now we know scientifically that what happens in keratoconus, the cornea becomes really sort of weak. When it becomes weak, it's like the eyeball is like a balloon filled with water. If cornea is weaker than rest of the eye, it's going to bulge out. So just look at those diagrammatic representation, that figure there. So in normal cornea, the corneal stroma is made up of parallel collagen fibers, and there are bridges or crosslinks between these fibers. In keratoconus, the number of fibers, the number of crosslinks, it goes down. There is displacement of these fibers on top of each other. Basically, the cornea just it's stretched out. So as I said, eye rubbing has really been studied closely as a factor that is associated with progression of keratoconus. There are researchers out there that firmly believe that actually eye rubbing can be associated with onset of the disease as well. So what happens is when we rub our eyes vigorously, uh, we we sort of this leads to the release of inflammatory cytokines. Cytokines are mediators in our tear film that act on the cornea and thereby kickstart a process of progressive ectasia. And because eye rubbing is somehow related to allergies in the eye, atopic disease, hay fever, eczema, bronchial asthma. You will see in young keratoconus patients, many of them, if you ask them, there's a history of bronchial asthma, which is really common in these patients. Oxidative stress has been associated, and I know that it sounds like cliche nowadays. You think about stress and oxidative stress and antioxidants in all the diseases, but it has been found in keratoconus that actually there is a lot of oxidative stress, and that has helped us to make that one of the treatment modalities better, and I'll discuss that about that as well. Other risk factors. Now, patients with Down syndrome, if you know somebody, they need to have their eye checked for sure. The prevalence of keratoconus and Down syndrome is really high. We Most of our patients with Down syndrome in the clinic are diagnosed with keratoconus. They present in their 50s, 40s, and 50s. Why so? Because nobody knows that they have to have their eye checks on a regular basis. But many times in Down syndrome, keratoconus presents in a more complicated fashion because it has been ignored for such a long time. And if you've noticed, patients with Downs, they'll rub their eyes continuously. Certain connective tissue disorders like Ehlers-Danlos syndrome, they are associated with keratoconus. Ethnic factors, it's more common in folks who have their lineage that can be traced back to the Middle East. It's slightly more common in tropical countries as well. And floppy eyelid syndrome is patients who have sort of upper eyelids that are more floppy than normal. They can have associated keratoconus as well. Now, I underline surgery because keratoconus begins when you are about 10, 14, between 10 and 15. And there's no exception to that rule really, except if you had surgery. So we still see a lot of post LASIK keratoconus, and these patients typically they present in their 40s and 50s again. What happens is um, sometimes, unfortunately, patients have surgery when they're not supposed to have surgery. They have thin corneas, they have other risk factors. With LASIK surgery or any other refractive surgery in the cornea, we tend to ablate the cornea, we tend to burn the cornea, if I can use that term, making it thinner. And that kick starts the process of progressive thinning of keratoconus. So clinical presentation, there's progressive impairment of vision, irregular astigmatism. Kids will come back and say, well, I can't see very well. And you're going to tell them, you just had your glasses checked 3 months ago. You take them back to the physician, they'll have another change of glasses. So frequent change in spectacles in early childhood, that's, it's a typical history in a keratoconic kid. You don't need to know about the epithelial iron deposit and scarring, but one thing that I'll show you a picture about later on is acute corneal eye drops. In advanced keratoconus, which goes undiagnosed and untreated for years, sometimes patients can present with fluid accumulation inside the cornea. I'll show you a picture, a better picture a little later in the presentation so it becomes more clear. One of the most devastating complications of keratoconus is acute corneal eye drops. As I said, early signs, it's important that you see your ophthalmologist if you have any of those signs, if you have any kids who have those signs on a timely fashion. Early signs can only be picked up in a physician's office. Late signs, when you actually can see the cone, they can be really picked up on torchlight examination as well. But by the time you see these signs, it's a bit too late. So we classify keratoconus based on the morphology of the cone. You can actually measure the size of the cone on a special device that's in the physician's office, on a device called corneal tomographer, which is again in a physician's office. Of course, a smaller the cone, um, we think better it is that the disease has been picked up, and we sort of understand the disease has been picked up at an earlier stage, so it's easier to manage as compared to if you have a picture which is sort of right here at the bottom. It's keratoglobus, as the name suggests, as compared to a nipple cone and an oval cone. A globus is going to involve the whole cornea, and that's why it's called keratoglobus, where the contact lens fitting becomes very difficult. Surgical intervention is also pretty challenging. Fortunately, keratoglobus is not as common as a nipple or an oval cone. This is just a representation of keratoconus on a device called OCT, optical coherence tomography. You see how this is a normal cornea, um, and the cornea from a side, it looks pretty normal in shape. Whereas in keratoconus cornea, where there's thinning in the inferior part of that circle, the circular cornea, you can see, there is some thinning here. And this is another variant of keratoconus called pellucid marginal degeneration, where the thinning is very, very sort of localized in the inferior nasal and inferior temporal quadrant towards the side of the cornea. And look at the keratoglobus cornea. So it looks really scary, and it's really difficult to manage as well. So in terms of management, you can use glasses, you can use contact lenses. Dr. Drexler is going to give you another talk about contact lenses in great detail. There was a lot of excitement about using these rings that go into the cornea, kind of support the cornea, the cone. And at the end of the day, when nothing works, you got to have a corneal transplant, which is a big surgery. But all of these treatment modalities, they improve the vision of the patient, but they do not alter the course of the disease. Your cornea will continue to progress, to thin out progressively, even if you are putting a contact lens on. So this is just another picture. I'm sure Dr. Drexler is going to have much better pictures. Look how this cone, in spite of being so huge and scary, you can have a large contact lens which sits way beyond the corneal margin. So again, as I said, Dr. Drexler is going to talk about contact lenses. A decade ago, look at this cornea from the side, it's so thinned out. We used to have only these options. You get glasses, if they don't fit, you get contact lenses, limited options in contact lenses. And if nothing works, go ahead and have a corneal transplant, which used to be a lifelong obligation from the patient side and also from the physician side, getting a corneal transplantation done. The new goals of management are halt the progression of the disease. You got to pick the disease at a really, really early stage, really, really early stage. And then you try and stop it or slow down its progression so patients will not have something terrible such as eye drops, or they would not need a corneal transplantation. And once that is done, you then visually rehabilitate these patients. This is what we do. So patients come to us or to Dr. Drexler in his clinic. We pick them, we select those patients and offer them surgeries as per the disease severity. And once our job is done, they go back to Dr. Drexler's clinic and they get customized fitting for contact lenses. So really the goal is to stop the keratoconus and reshape the cornea. One of the surgeries that was recently in 2016 actually approved by the FDA, US FDA, was collagen cross-linking. Now, collagen cross-linking was devised by the Europeans back in 2003. It was described for the first time in 1998. Um, just by the virtue of work, my training in another country, and I've worked in a few other places. I've been doing collagen cross linking since 2008 or 8, I think. Um, but FDA approved this wonderful surgery in 2016. So what happens in collagen cross-linking is basically, so this is the cornea. We scrape off the skin from the cornea. It's a thin layer, and you put some numbing eye drops, scrape off the skin. Once the skin is scraped off, you put these yellow drops, they're riboflavin or vitamin B eye drops for half an hour. Once that is done, you shine a blue light on the surface of the cornea. So what happens is actually the combination of riboflavin and UV light, the blue light, it creates oxygen species. Remember I talked about the oxidative stress, and those oxygen species, actually singlet oxygen species, they enhance the formation of um, crosslinks in between the corneal collagen fibers, thereby making your cornea sort of stronger, brittle in a way. But at the end of the day, the goal is to stop the progression of the disease. So this is just a diagrammatic representation, again, how there's a frame shift in the biomechanical strength of the cornea from a lower level to a higher level in a keratoconus cornea. And this is a cross-linked cornea, and that's a normal cornea. So that's how cross-linking helps. So in addition to that, it's very, very useful for a healthcare system. It's useful, absolutely fantastic to save millions of healthcare dollars. It has been shown that if you do collagen cross-linking in a timely fashion, you're actually gonna help save the patient from getting a transplant surgery done, which really, really means a lot of obligations, as I've mentioned, for the patient, for the family. Patients will always come back for follow-up. So one surgery after another surgery, it's a really, really sort of difficult, but we got to do it when we got to do it, but we try and prevent it as much as possible. And of course, reduction in need for corneal transplantation means not only we save healthcare dollars, we also save the corneal tissue, which can be used for other patients who really need them. There are different kinds of collagen cross-linkings. Of course, somebody described a simple thing, we had to complicate it. But without going into detail, I can tell you that each type of collagen cross-linking has been designed to provide a customized treatment to a specific patient. The only collagen cross-linking type that has been approved by FDA is conventional cross-linking. It takes a long time. Uh, Back in Hong Kong, where I used to work before that, we used to do the high fluence or accelerated cross-linking, which only takes about half the time as compared to conventional cross-linking. We can also do a transepithelial cross-linking, which really means you don't have to remove that skin, as I showed you in the diagram. But yes, there are certain limitations. Hopefully by the end of next year, we should have high fluence collagen cross-linking approved by the FDA as well in the United States. Well, when collagen cross-linking is not an option, which is when the corneas are too thin to be collagen cross-linked, you got to move on to the next step, which is called a corneal transplantation. So 15, 20 years ago, for every corneal problem, we will take all the corneal layers and we will replace that with a fresh cornea from a donor. But eventually we realized that that's a huge therapeutic overkill. So in keratoconus, only the interior part of the cornea is involved, not the posterior part of the cornea. So we started doing only interior corneal transplantation. So your surgeon will explain this to you. Instead of removing the whole cornea, they will dissect off the superficial part of the cornea. They will take a donor cornea, put it on, and then sew it. Again, sort of a diagrammatic representation. This is a line diagram. See how this part of the cornea, which is affected in keratoconus and other corneal ectasias, that can be replaced while you retain the posterior half of the cornea. This is called partial thickness or lamellar corneal transplantation. The biggest advantage is that the chances of graft rejection are really, really low. Some photographs showing how the corneal transplantation works. This is a patient with keratoconus globus. Another patient, see how side view, the cornea is really, really ectatic. And after the surgery, this is day one or day two after the surgery. Old pictures, but still pretty relevant. So, so I want to just spend 5 more minutes quickly on, looking into this, if I can look into the future. um, our team identified um, the basic issues where we are lacking in terms of keratoconus research. So the first thing is understanding the pathophysiology. Why does it happen? Can we stop it? So this is one of the studies that we published a few years ago. I just want to show you, look at the difference in the skin in a normal cornea. This is just the skin. It's pink, nice. The cells are sort of, they're happy, they're everywhere, as compared to a keratoconic cornea, where the inner part of that skin is sort of broken. There are breaks here, and look at the number of cells. There's so few. So we actually started looking at these markers, and there's a significant difference between control corneas and keratoconus cornea. So um, now what we're trying to do is we're trying to harvest the skin during surgery from these keratoconus patients, and we're trying to look at specific inflammatory markers. And we hope that as this research progresses, we're gonna see potential targets that can be used to slow down the progression of the disease, or even to prevent the occurrence of keratoconus in certain group of patients. The second thing we're trying to do is better treatment modalities. Now, collagen cross-linking, it has got its own limitations. It can only work for certain corneas with certain thicknesses. It doesn't work very well for certain groups of patients. So with colleagues in Duquesne University, we are trying to, this is basically a pig eye. Sorry for this scary picture here. It's in a yellow pool, which is actually basically riboflavin. So we are trying to enhance the oxygen delivery. Remember, I told you about the oxidative stress again. Um, we're trying to enhance the permeability of oxygen into the cornea so as to increase the efficacy of collagen cross-linking in corneas. And the third thing, which is really, really important and relevant nowadays, is how can we reverse corneal scarring? So with Gary Yam, who's a PhD and our research assistant professor, we've been trying to work, on looking at certain markers, identifying them. There's so trying to see if we can find a good balance between the pro-inflammatory and anti-inflammatory markers, pro-scarring and anti-scarring markers. Um, so again, always the challenge is these experiments, they can last for years, and then we have to be really, really patient. But fortunately, we are moving in the right direction, and hopefully with some right kind of support and funding from the federal government as well, we'll get somewhere in terms of looking at reversing the corneal scarring once the scarring sets in advanced keratoconus. Um, Very important bit again. I know I've talked about eye rubbing. So Many countries, mainly in South America and Asia, they have screening programs for normal population. So you don't have any issues, that's okay. You still can come once a year and get some education about how to rub your eyes and how not to rub your eyes, more importantly. And you can get this corneal tomographic scan, which can, in about 97% of cases, it can pick up keratoconus. We are hoping to set up a screening and education program at the Ioneer with the help of Dr. Scott Trexler and his team. So we'll see how this is just a very beginning of this kind of program that we want to get into. So this lecture cannot finish if we don't talk about pediatric keratoconus. This is a disease that starts in teen years. Children are at higher risk for progression. Children rub their eyes all the time. They might need a retreatment. Visual rehabilitation is a huge issue. Try putting a contact lens on a 7-year-old's eye, and you would know what I'm talking about. And there are a lot of complications that can be associated during this treatment. And we consider anyone with Downs, to be a child with certain level of mental ability. So this is corneal hydrops in a kid. So this is a normal cornea, but actually it's a keratoconus cornea, but I'm sort of be going backwards. Uh, there's a lot of swelling when patients present with high drops, that swelling, that fluid accumulates inside the cornea because there are so many breaks, the breaks that I showed you in that skin on that colorful picture. And we have to go take the patient to the OR and inject some air bubbles so that it can seal the break so the recovery is faster. See how the cornea looks like here on OCT, all swollen. And now you can see the break after the surgery is done. We have to seal this break. And this is post-op after 2 years with a huge scar. And look, the cone is still pretty visible, although the recovery has been pretty good. And the vision was only counting fingers. And after the scar has been, set in, the patient can only see 2200. That's the biggest letter on that Snellen chart. So that's how poor the vision can be once the scarring sets in. And that tells us the importance of improving our treatment modalities and diagnostic capabilities in keratoconus. So I really want to thank Dr. Gary Yam. He's a research assistant professor. He's helping us a lot with corneal regenerative projects. Dr. Prakash recently joined us, actually a year and a half now, from Abu Dhabi. He has seen the highest number of keratoconus patients because he was in the Middle East and the prevalence is really, really high. I want to acknowledge Dr. Yishin Du, associate professor in the cornea labs, Deep Daliwal, Alex Mammon, and Rohina Kamiar are the cornea division members. Ken Nischel is the division chief of pediatric ophthalmology. He's the cornea chief as well. And actually, we set up collagen cross-linking at the children's hospital first before we could get it on the adult side, and which was the right thing to do at that point when I joined the department. Of course, the man himself, our chairman, Dr. Sahel, who's always been very supportive of all these in all these endeavors. And whenever we need anything, we just knock on his door. Thank you very much for your attention.
Okay, I think, oh, there you go. Dr. Drexler's ready. Okay.
Okay, thank you, Dr. Janji. That was wonderful. I'm Scott Drexler. I am the director of the Specialty Contact Lens Service at the Eye Center of UPMC. And I'm here today to talk about a little bit about non-surgical visual rehabilitation, especially in the situation of keratoconus. As Dr. Janji said, if we can do things that productively keep people seeing and also at the same time allow us to not have to do surgery on them, it's a win-win for everybody. Goal of rehabilitation is not always 20/20 vision. The real goal to me is to take what I can do to customize the optical correction to meet the visual goals and needs of the patient. And, even though I have a medical history in front of me when I sit with a patient, I always ask them first, why are you here? What brought you in? What's your personal motivation? Is it work? Is it driving? Is it something you have a hard time doing? What part of your life, what part of your day do we need to help you with to make you function better? And And that's something that really helps us customize those treatments. Whatever we do, it helps me pick the best way to help them. So you heard before that medically keratoconus is when the cornea gets steeper and thinner. Right? Visually, keratoconus is really a shape problem. Right? When you think when you get an irregular shaped cornea, optically it causes not just distortion, not just blur, but distortion. Right? When that cornea gets out of shape, the light going through it can't go through it clearly. So it is diffracted, it's split, it goes in all different directions. What that does is it induces a lot of higher order optical aberrations, in particular, a couple called coma and trefoil. Both those things are the things that when you have keratoconus and you see things, you look, it's not just blurry, it's distorted, it's glare, it is light sensitivity, it is starbursting. Those things don't come from the power, they come from the shape of the cornea and the optical aberrations that are induced by it. So how can we recreate a good optical surface to restore vision? What do? These are listed here from the simple to the more complex. Right? And if you think that we want to customize our treatment to the patient, I don't want to use a complex solution to a simple problem. So that's why it's really important to know the state of the keratoconus. How far along is it? What does the patient really need to be happy with their vision? And that's a really broad spectrum. I've had people who were 20/20 and not happy, and people who were 20/80 and very happy. So you really have to make sure you know what the patient needs to be functional. Eyeglasses are the simple thing. Soft contact lenses, there's different types of soft contact lenses. Rigid gas permeable contact lenses, which is a hard contact lens, a hybrid lens, and then scleral lenses. Eyeglasses are something that usually are the first line of treatment. Right? But remember, we're saying that really the vision problems with keratoconus are shape-related problems. Eyeglasses have a power, but they don't address the shape-related problems. That's why so many keratocones will put a pair of glasses on and say, these don't help. These don't do anything for me. I don't even bother wearing them, even though their prescription is very high. And the glasses do correct the astigmatism, but they don't actually improve the visual quality. And that's probably equally as important. So it's not just good acuity, but quality vision that makes the difference. Eyeglasses typically work really well for a mild keratoconus. The more advanced they get, the less likely it is to work well. And they're really good even in a more advanced case for an emergency backup. I need to function around the house to just do basic things. They work for that typically, but they aren't going to be a high functioning thing. Soft contact lenses, I'm sure you're all familiar with. A standard soft contact lens, it molds to the cornea, it drapes over the cornea. Kind of like a pair of glasses, it doesn't really correct any of the shape-related problems. So it can correct the astigmatism, it can correct the nearsightedness or farsightedness, but it doesn't really do anything to kind of take that shape problem away. There are a couple specialty soft contact lenses. One's a Novacone, one's a Kerasoft. Both these lenses are designed so that the optical part, the optics of the lens, are there to mask some of the shape-related problems. And I use that word mask specifically. It doesn't correct it. It doesn't recreate the surface. It kind of hides it a little bit. On top of that, it can correct the astigmatism. These, again, work really well for mild keratoconus. And they're also very frequently a good starting point. It's a jumping off point. When somebody comes in, if you have somebody who hasn't worn a contact lens before, isn't really too excited about touching their eyes, a younger person who doesn't really want the contact lens to begin with, it's a great place to start. It gets somebody into a lens, it gets them better vision. It might not be 100%, but it gets them better vision. And they're easy to handle, they're easy to insert, they're easy to remove. It's just kind of a nice place to be, and especially in a mild keratoconus. Next step up is a gas permeable lens. It's a hard contact lens. This is where we get into better optics. The rigid surface actually recreates the optical surface of the cornea, so that when you saw those pictures of the very irregular, very steep surfaces, it actually recreates it. It makes it smooth and even again. That gives us a pretty good visual result. It can correct the astigmatism, and it can correct nearsightedness and farsightedness. But with these lenses, because it's a hard lens that rests on the cornea, comfort and stability are frequently issues. When any lens rests on the cornea, the corneal nerves know it's there, and it can be everything from a mild discomfort to a major discomfort. The lens that I personally fit is it's a topography guided hard lens, topography guided RGP. I use a system called the wave system, which if you look down below on the right side, you'll see that colorful diagram. That's a topography. That gives me the shape of the cornea. The reds are the steeps, the blues are the flats, so you can see how irregular that cornea is. A soft contact lens isn't going to help that. The diagram on the left is actually a CAD program. It's a computer-aided design program. And I can take that topography, put it into a computer program, and actually design a lens that matches the shape of the cornea, which makes it much more comfortable, makes it much more stable, and allows me to correct a lot of the prescription, even the astigmatism. And these lenses, because your average gas permeable lens will probably be 8 to 9 millimeters, these lenses are much bigger, which makes them more comfortable, makes them more stable. Next step up from that is a lens, it's a hybrid lens. So remember we said that the difficulty with most RGPs is comfort and stability. Hybrid lens is half soft, half hard. So the area, that purple area down here in the middle, this is all a hard lens. This area around the outside, the tan area, is a soft lens, and they're bonded together. And the soft skirt gives me good stability and much better comfort. You still feel it. It's not 100% comfortable, but it's much better. And it actually holds the optical part of the RGP where we want it to be. So it won't pop out, it won't dislocate, and it lets us put the optics where we need them. Another good thing too is that from a handling point of view, you can put it in and out like a soft lens too. The downsides to these lenses, one is that they can only correct a limited amount of astigmatism. I can't put more astigmatic power in the front of the lens like I can with a lot of the other lenses. And because of how the soft skirt is, it sits very stably, very still. And peripheral cornea tends to get blood vessels growing into it. It's called corneal neovascularization. This can end up being a significant problem for some people too. And the newer hybrid lenses use a very oxygen permeable skirt, which helps this, but it's still commonly an issue. Lens I fit the most is actually a scleral lens. These are basically an RGP material, but in a very large diameter. So I think that a gas permeable lens, even the bigger ones I fit, about 10 millimeters. A hybrid lens, about 14.5 millimeters. A typical scleral lens that I fit, usually about 19 to 20 millimeters. And lens, when you look at it, can be a little bit intimidating, but the great thing about it is that the lens actually rests on the white area of your eye, the scleral conjunctiva. It doesn't touch the cornea, it doesn't touch the limbus. So if you have a compromised eye, if you have somebody who has a corneal scar, who has poor stem cell function, we can still fit this lens and just stay away from that tissue completely. And from my point of view, from a vision point of view, because the lens sits stably, I get better optics and there's more flexibility with the optics. I can take that lens and I can kind of customize it to the person. This is an OCT picture, the optical coherence tomography. And this is a scleral lens on the eye. Remember, we were saying how we can really kind of control how these lenses fit. This top white line here is the front surface of the scleral lens. The next white line down is actually the back surface of the scleral lens. And so you can see the space between the back surface and the front surface of the cornea. The whole way across the cornea. There's not a place that lens is actually touching the cornea. So we don't get abrasions. We don't get a lot of the things we tend to get with the mechanical irritation of an RGP. This area over here where it goes from dark to light, that's the limbus. And you can see above it where the scleral lens doesn't touch that part either. It stays away from that tissue, which is relatively delicate. And then this part over here, the foot of the lens, the haptic of the lens, is where the lens rests on the white part of the eye. And I have a blown up picture of that, and you can see the lens comes into the sclera, comes into the conjunctiva, pushes against it, and then this area here where the limbus is in the cornea, there's no contact between the lens and these areas here. Keeps the tissue healthier, keeps the lens more stable, makes it much more comfortable. And, this area here, and why I like fitting larger lenses, this area across here, the wider this area is, the more the weight of the lens is dispersed across the sclera, which makes the lens more stable and more comfortable. The lens that from a scleral lens point of view, the lens I fit the most is a Boston Sight lens. I can design this lens using a CAD program. It's usually a 19mm lens. I can change any meridian, any curve in this lens in 50 micron steps. So if I have an area that's a little too tight, I can modify it. If I have areas a little too loose, I can modify it. And I can also modify the optical eccentricity. So if you saw the pictures that Dr. Janji showed, that cone wasn't always in one place. That cone might be inferior, it might be central, it might be up higher. There's no rule of thumb as to where that cone is. If I put the optics of the lens where you're not looking, you're not going to see well, even if I have the right power. I can change the eccentricity. I can decenter the optics of this lens to put it where it needs to be, and it compensates for some of those higher order aberrations that we're trying to get away from. We just started working with the Boston Sight group, and we're doing a clinical trial to find ways to directly add the higher order aberrations from an eye design system. The eye design system is what we use to do custom LASIK. It's a wavefront system. It takes a reading of all the higher order aberrations and gives them back to us. Because these lenses sit so stably, once we put it on, it rotates into place. We can take that higher order aberration information, put it on the front surface of the lens to give us better vision. And hopefully that will kind of decrease some of those distortions that people get. Even when they see 20/20, they'll see shadows or ghosts. We're trying to get rid of those to get a better quality image for them too. The back surface, and if you look down at this image here, you'll see these channels, these little markings across here. These are basically things I can put into the lens to either avoid obstacles, a bump on the cornea, a scar. I can avoid those, or I can just use them to kind of increase the fluid exchange behind the lens to keep the cornea healthy. The Pros Design, which is another Boston thing, is basically a Boston Sight lens with a much more advanced CAD program. So it really allows you to make many more fine changes to it and greater changes. The Pros device, we're just in the final stages of getting access to that, and we should be able to have it by summer, we're hoping. Next step up from a Pros or a Boston Sight lens is something called an iPrint device. This is actually an impression-based scleral lens. It uses a dental mold, a polyvinyl siloxane material, to actually go onto the eye. It's a two-part material, so we mix it together, let it sit for 1 minute. We put it on the eye, let it sit for about 2 minutes. It goes from being kind of a semi-liquid to a solid. It actually gives us a precise mold of the whole front of the eye, the whole ocular surface, down to about 3 microns. The fact that when you look at these molds, you can actually see where the tear film was. These lenses, again, because they sit stably, we should be able to add those corrections for the higher order aberrations too. The picture you see here is actually the mold material on the eye. Even though it looks like it's kind of uncomfortable, we don't use anesthetic for this. 2 reasons. One, we don't need it, but the second reason being is that the anesthetic itself will actually distort the mold. So when we take this mold, once we take it off the eye, this blue picture here is what it looks like. It gives you an impression of the whole front of the eye. This mold is digitized into a image like this. This image is then printed and it uses the form for the lens. This is the custom lens that came from this mold, and it's an identical replication of the front surface of the eye, and this is what it looks like on the eye. you can see that you really can't even see the edge of the lens anywhere all around. The green that you see is actually a dye we put in the lens so we can see where the lens is and what it's doing. Future developments, and you look back at all these things and you see that they're relatively technical, they're relatively difficult, they're time consuming, it involves a lot of footwork, and it's something that really kind of limits people's access to it. So what we're hoping in the future to really kind of get to the point that it's reliable, which we have access to some of these things now, but the image on the left is a topographer. It gives us a map of the front of the eye without no contact. It just takes a picture of the front of the eye, gives us a digital image like this, which we can in turn turn into a lens that actually matches the front surface of the eye entirely. This is something that you can take an image, order a lens, have the first lens that you put on be right where you want it to be, and just fine tune the power. I think in looking at all those things, our current technologies are good, but I feel strongly we need to make them more accurate, more accessible to both the providers and the people who need them. The easier they are to fit, the more people who can do it, and the more people who have access to them. And in the end, if you think where our goal is to customize these treatments, the right choice of a lens, for me, is the simplest one that fulfills the patient's needs and works in their life. If they can't get a lens in, it doesn't help them. If they can't handle a lens or take care of it, it doesn't help them. So we need to make sure that whatever we do as far as rehabilitation, we get a system that works for the patient and they can make it working every day. Thank you.
Well, thank you both. That was a very, very thorough, as we said we would, coverage of current and future planned treatments for keratoconus. And I have to say, I learned a lot from it myself. There's certainly a lot of practical things that can be done, but it still sounds like a very complex condition. And judging by the number of people who attended our webinar today, obviously others feel the same way. So I'm going to get to the questions here. We have many, and thank you both, if you would, to answer those. So the one here regarding what are the prospects for corneal tissue in addition to keratoconus treatments? Is there an investigational technique where the eye bank tissue is inserted to the cornea to thicken it?
So I already answered that, but I can, of course, say that again. Additive technologies have been in vogue for many years now, and I showed the picture of those intracorneal rings. They don't work very well for everyone. There is a continuous ring actually, which was never approved by the FDA. It's available in the Middle East and in Europe. Adding tissue to the cornea has been recently described by folks in India, and actually Dr. Prakash used to work with the same group about 10 years ago. Long-term follow-up is the way to see if this is actually going to be useful. It does make sense in theory, but the main challenge is when you add tissue to the cornea, eventually cornea doesn't have any blood supply. That tissue is just gonna degrade over a period of few years, so the effect is gonna go.
Thank you. There's a lot of questions here. Some of them I saw that you get a chance to answer while we were doing this, but I'll read them for other folks who may appreciate it as well. At what age do parents with children with Down syndrome need to have their eyes checked for keratoconus? Is there anything that they can do?
Yeah, so for the kids, as I said, I mean, as soon as you think the kid is able to, sit on an exam chair, it's not absolutely necessary for every kid to sit on an exam chair. We have these handheld devices which we can, use. Ken Nischel sent a 4-year-old girl um, last month. That was the most cooperative 4-year-old patient that I've ever met in my life. She was able not only to get her exam done, but we could do a corneal tomography scan. And I can tell you, we have problems with adults keeping their eyes open. So really, as early as possible, as early as you think that the kid's gonna be okay, not freaking out in a eye clinic, which can, you know, we take care of a lot of patients with Downs, and Dr. Drexler takes care of these patients more than I do. He's been looking after them for years, and Dr. Smith looks after these patients as well. We are very patient. We know that we don't want to lose that opportunity. The patient is in the clinic, has got other issues, is differently abled. So we take our time to make sure that we get the data that we want before the patient and the parents leave the office.
Thank you. So is collagen cross-linking surgery, is it risky?
So again, every surgery is risky. Well, collagen cross-linking is an extraocular procedure. Remember how I showed you got to remove the skin of the cornea. So basically, as long as the cornea doesn't have a skin, you are at risk of getting an infection. The risk is really, really low. So the risk benefit ratio in collagen cross linking is really low. It's really low. Yes. So the benefits are way more than risks. Whereas this thing that we used to tell patients when I was in Melbourne, that they used to ask, "What's this risk for this ocular surgery?" We used to tell them the risk of you getting hit by a vehicle when you are walking on a side path is about 1 in 8,000 in Australia. And the risk of getting infection after eye surgery is about 1 in 7,000. So you can very well imagine that it's not going to be very risky. Yeah, so it's, I would say yes, it is. Every surgery has a risk, but it's very, very low for cross-linking.
So is keratoconus different from age-related cornea issues that require surgery?
Yes, yeah, it is. And I know the symptoms for every eye problem, they sound the same. It's like saying that, hey, I have pain in my leg. Do I have sciatica, or it's just I need to get a new pair of shoes? You really can't tell. But keratoconus starts early in life, unless you had surgery, as I mentioned during the presentation. So, if your kid rubs his or her eyes, and, again, complains of frequent change in glasses, it's not a bad idea to. And I tell you, most of a huge chunk of these patients, they come from the optometry practices. The optometrists, they have been looking after them for 10 years, and suddenly they can't refract them, they can't give them new glasses because their astigmatism is really bad. And that's when they say, well, there's something odd about your cornea, go and see an ophthalmologist. So that's how we come to know.
I think this may be for Dr. Drexler. I understand that contacts for keratoconus are extremely expensive. Are there programs or insurance to help patients acquire those specialty lenses?
That's a great question. Some of the lenses, not all of them, some of them tend to get pretty pricey. So as I said, if you look at the hierarchy of things that we do, the more simple things are less expensive. You get up to a scleral lens, an eye print lens, a pros device, they can get pretty pricey. So that's part of making sure whatever we do, we work into the needs of the patient. Fortunately, there are a lot of insurance plans. So the way it usually works out is that the vision plan, the eyeglass plan, will usually be what covers the lenses. The medical plan is usually what covers the fitting. So if you look at your insurance plan, the medical plans usually will not cover the lens itself, but some of the vision plans have very good coverage for the lenses themselves. So look into it.
That's great to know. Would someone like you with your skills, Dr. Drexler, how rare are you? If you're going outside of the region here around Pittsburgh, are there many people doing this kind of specialty contact lens fitting?
There aren't a lot of people doing it. That's why one of the things I said, the accessibility. The way fits are done now, they're kind of protracted. It takes time for the fitting. It takes time to get a lens on the eye. It takes a lot of chair time, a lot of patient time, and a lot of private practices don't have the time to do that. So for us and there, if we can find a technology that kind of streamlines all that, the availability will be a lot better.
So this question actually refers to, I kind of have shared the same question. What is the best way to rub your eye? You mentioned in there that obviously that we can cause damage. What is the best way to rub your eye?
Well, so there's no best way to rub your eyes. I can answer this in a different way. You can ask, what is the worst way to rub your eyes? So we've noticed that, and it's not only us, researchers around the world, that keratoconic patients and patients with Downs, let's just say, they'll rub their eyes with their knuckles. You know, they go really deep. Sometimes they'll rub their eyes with the back of their wrists, and they go really deep. And they rub their eyes continuously, or they'll start once and they wouldn't stop for a good 2-3 minutes. That's a long time.
Yeah.
You would know someone's rubbing their eyes when they do it, during a routine conversation, isn't there? Um, uh, there's a guy, a researcher, ophthalmologist, MD PhD in Switzerland, Farhad Nafazi, and we were attending one of his presentations virtually, of course, in November. And they actually created a model where they're trying to gauge the force with which we actually rub our eyes. There's a researcher back in the UK who has done live scans. When you rub your eyes, they've shown how much you actually indent your globe, your whole eyeball in. Of course, that is the extent of rubbing. We still don't know how much rubbing is going to cause what, to what extent. We also don't know how one patient will say, look, I never rubbed my eyes. How do I have keratoconus? And somebody else will say, oh, I rub my eyes all the time, but I don't have keratoconus. So there's very certain unanswered questions. One thing is for sure, if you have keratoconus, do not rub your eyes. If you have Downs, or you have somebody around you has Downs, make sure they don't rub their eyes, because they are high risk people, high risk population. They need to be protected for sure. And similarly, if you had a corneal transplant done, you don't want to rub your eyes for sure.
So others might have the same question as well. You mentioned the tissues or the issue of oxidative stress. Is there anything you can do with vitamin supplementation to lessen that risk?
Yeah. So I'm glad somebody asked this. So really nothing. Okay. Now this oxidative stress is, it's a very sort of deep rooted statement. I don't want people to go home with this message that there's oxidative stress, you take antioxidants and then you're going to be fine. No, you're not going to be fine. So I always tell my patients, eat healthy. If you need antioxidants, you get it through your food, you get it through your supplements. Food is better than supplements, obviously, any given day. you know but yes, really, there's no particular diet that's going to help you more than other. Of course, if you eat healthy, if you stay well, you're going to be okay anyways. So, but there's nothing specific for keratoconus.
So you mentioned the intrastromal corneal ring implants. Is that how many patients, what percentage of patients with keratoconus require that?
Well, it really, so the way these, sorry, my messages just keep popping up. The way the rings work, these rings. So imagine a cornea, which is a good, like a perfect hemisphere or a semicircle. The cone is sort of hanging, as I showed in a few pictures, from the front of the cornea, because of gravity mainly over time. So the rings are supposed to go below this hanging part and sort of lift it up, providing support to this cone. Um, every patient is different. They used to, and every phase is different. When cones were introduced, they were introduced for something else. Then people found out, oh, they're going to be good for early keratoconus. But then cross-linking came up, And now the people still in South America, also in India and other parts of the world, they do rings with cross-linking. So remember what I wrote on the slide was all these modalities are gonna visually rehabilitate you, but they are not gonna stop the progression of the disease. You need to have cross-linking, and for you to have cross-linking, it is important that keratoconus is picked up at an early stage, so you are still suitable for getting a cross-linking done. Right now, that is the only procedure, but this is not going to be the only procedure. Things are in the pipeline, they'll come. We are doing certain things, with scarring as well. We'll see with regenerative corneal medicine. Hopefully, we'll see better modalities. And actually, I shouldn't say better modalities, additional modalities in addition to what we have, which is collagen cross-linking right now.
Well, thank you both again. We just ran to the end of the hour. I think we did get almost every question. There's a few that we'll follow up with that may be more individualized. But this is a obviously very interesting program, and thank you for putting this together. There's and it's very encouraging, one, that you're finding answers for people that are suffering, that we can correct with some of the rehabilitation work. But it's also encouraging, as you presented, Dr. Janji, that we're also working on some of the things that may be regenerative, where we can actually restore vision. That's obviously very encouraging for everybody that's out there that's looking for those answers. Hang on tight. We'll keep working on them. We'll certainly keep doing the research. It's what we do, and it's what we support through the Eye and Ear Foundation. So thank you for attending, and we'll look forward to the next program, which you'll get an invitation to in the coming weeks. Have a good day.
Thank you. Good day to everyone.